Hello everyone, my name is Sparrow and I'm pleased to welcome you to today's MHS webinar entitled ADHD Assessment Across the Lifespan, presented by Dr. Elizabeth Sparrow. This webinar is part of MHS webinar series Unmasking ADHD Practical Strategies to Empower Youth and Adults. We are thrilled to have you all here with us today and would like to begin by telling you a bit about MHS Clinical and Education divisions. MHS Clinical specializes in aiding the identification and treatment of psychological disorders for improved patient outcomes at all stages of life. MHS Education specializes in providing the expertise and resources required to help children and adolescents reach their full potential in and beyond the classroom. With our advanced suite of tools, team of experts, and robust data sets, we help clients provide comprehensive evaluations and uncover powerful insights. Now, without further ado, it's my great pleasure to introduce to our presenter today. Dr. Sparrow is a licensed psychologist in North Carolina, providing neuropsychological evaluations and clinical interventions through her private practice. Her engaging and informative presentations draw from 40 years of experience with ADHD, including clinical practice, major development, and authorship. She is dedicated to accurately identifying individual strengths and challenges to create effective action plans. In addition to co-authoring the CAARS Adult ADHD Rating Scales, which is CAARS, and CAARS 2, Dr. Sparrow has served as the lead clinical consultant for the CAARS 3, CAARS Comprehensive Behavioral Rating Scale, and CAARS Early Childhood. She has led skill-based workshops, created and delivered clinical training, and provided case consultations. She co-authored Essentials of ADHD Assessment for Children and Adolescents and Guide to Assessment Scales in ADHD, second edition, co-edited Executive Function and Dysfunction, and authored Essentials of CAARS Behavior Assessments. Participants have consistently described her webinars as insightful, applicable, well-organized, and enjoyable. We are so glad to have you here with us, Dr. Sparrow. As we begin our presentation, I again would like to quickly remind everyone that there will be a survey sent to you in order to satisfy CE credit requirements. If you do not receive this email before the end of the session, then please send us an email at marketing@mhs.com so we can send it to you. Now let's start the webinar, and I'm handing over to you, Dr. Sparrow.
Thank you, Parul. It is an honor to be here. Thank you for asking me to speak about this important topic. I can never begin talking about ADHD without acknowledging these valuable partners. Drew Earhart and Keith Connors and I have collaborated for decades, and my collaborations with MHS have lasted just as long. Thank you all for your part of this. A few quick housekeeping notes. Please grab some scratch paper or a virtual pad for some exercises we'll do during today's presentation. And MHS is providing a handout file. Check the QR code on screen or the link that Parul is dropping into the chat. One final note, when I'm describing results from research studies, I will use the terminology used by those authors at the time the work was published. The intended audience for this presentation is credentialed professionals involved in diagnosis and treatment of ADHD. It's really important for the general public, attorneys, parents, teachers, other professionals to know about ADHD, but this presentation does not provide sufficient context for that audience. I assume you have core knowledge of DSM principles as well as basic principles of assessment and treatment. A couple of resources if you would like a deeper dive into some of the topics we will cover today. Here's the book that Drew Earhart and I co-authored. Link to a webinar we provided 2 years ago about assessment of ADHD in adults, and the webinar from last year looking specifically at the transition from adolescence into early adulthood. The learning objectives were provided when you registered. And I'm adding a bonus topic, looking at various contextual factors that will impact your ADHD assessments. Here's the plan for today. Let's start by focusing on a person. This is a 25-year-old woman who is self-referred. She read about ADHD online and has no prior diagnosis, and says that she often feels overwhelmed managing her everyday life. We'll come back to this person at the end of the webinar. Every section, I will begin with a blue reflection slide. This is my goal, to make this a more interactive, engaging webinar for you, so you're not falling into passive consumption mode. Every time you see one of these blue slides, please grab your pencil and paper and jot down your reflections. Why does context matter? Well, first of all, why are you here? Why does ADHD matter to you? Why does it matter to the people and families that we work with? I'll tell you why it matters to me. It matters, I care about this accurate lifespan assessment because I want people to have access to knowledge, supports, accommodations, and interventions. It's not just us who care. Looking at Google searches for ADHD over the past 20 years, you see a rise worldwide and in the United States. You also see an increase of the diagnostic rates as you look over 2010 to the current days. It's really important that we have responsible answers for all these people who are looking for information and getting new diagnoses. We need to offer facts and evidence to balance out the misinformation being generated by AI, social media, and other sources. How prevalent is ADHD? It's pretty prevalent, and these numbers may be underestimates. It's really important when you look at prevalence data to remember what is the methodology. This does not tell us the actual rate of ADHD occurring in the world. This tells us what is the rate that it was detected in the population being studied. We're going to look at some other factors that impact who is diagnosed and who is not diagnosed, because that has a huge swing on what the prevalence rates look like in various groups. Does ADHD last? Yes, it does. This longitudinal study of children with ADHD found that 90% of this childhood sample continued to have symptoms of ADHD as young adults. However, if you looked at them at various points in time, you might have found times when they did not meet criteria for ADHD. Looking at 10 years old to 25 years old, 64% of the sample had times where they looked better or worse during that period. This is important because it can be encouraging for individuals and their families to know that there could be periods of remission or reduced symptoms. And this is another reminder that it's important to continue monitoring symptoms of ADHD instead of stopping monitoring and stopping intervention just because someone's looking better. Comorbidity is a big part of ADHD. About 80% of adults with ADHD have at least one and often more than one co-occurring condition. Most commonly co-occurring conditions are depression, anxiety disorders, substance use disorders. Some studies find people with ADHD are more likely to have PTSD after trauma. And a surprising statistic that is not often quoted is that several studies have found that adults with ADHD have higher rates of sexually transmitted infections than the general population. Looking at comorbidity for children and youth, this looks at 3 to 17-year-olds with ADHD. You see 78% of them had a co-occurring condition of some sort. The largest percent were behavioral or conduct problems, followed by anxiety, learning disability, developmental delay, and depression. But what changes if we start breaking this group apart? If we look at these same children with ADHD, but divided into three age groups, 3 to 5 years old, 6 to 11 years old, and 12 to 17 years old, you see some of the patterns shifting. What happens with behavioral and conduct problems? I see a reduction, but where do you see an increase? Yep, the anxiety and depression are increasing over this age span. It's important to remember that because that shifts what we need to look for clinically in our assessments. What about by gender? Same sample of children, boys on the top, girls on the bottom. The study did not reference non binary groups. What strikes you when you look at these data? Boys were more likely to have behavioral or conduct problems. Girls were much more likely to present with anxiety and depression. The autism comorbidity shifts also, but I think that's a more complicated matter. There's a lot of emerging research on how we're missing autism in girls. So I'm going to sidestep that one for now. So what do we know about ADHD in girls and women? We know there's a referral bias in childhood. So there was a really cool study where teachers were given descriptions of students. Some of the descriptions used she, hers, and some of them used he, him. Teachers were more likely to refer those with he, his for an ADHD evaluation. Same studies, only differed in gender assumptions. Parents tend to underestimate impairment and severity when they're rating girls. And societally, girls tend to have more compliant, acceptable behaviors, often masking their impairment and difficulties. Some of those subtle coping strategies end up with long-term cost, especially those where these girls are avoiding interactions with others, retreating to online, not asking for help. Another key reason for this referral bias in childhood is level of disruption. Parents and teachers are more likely to refer the students who are disruptive. If we look at the prevalence of different ADHD symptom profiles, boys are more likely to present with hyperactive impulsive features, which accompanies being more disruptive. Also remember from that last slide, higher rates of disruptive behavior disorders that are comorbid with ADHD in boys. Whereas girls are more likely to present with inattentive features and often fly under the radar, are not causing problems at home and school in the same way that the boys are. Another reason that they're not being referred. Women can self-refer, but their presentation does not fit with the typical ADHD in the DSM. Women are more likely than men to endorse symptoms of social and verbal impulsivity, like excessive talking, blurting out answers, fidgeting, interrupting, and intruding on others. Now, the DSM does not mention giggling, but that's another finding that girls and women are more likely to have excessive giggling when they have ADHD. So in addition to these shifts in the gender-related symptom profile, we also talked about the comorbidities a few slides ago, that lower rates of externalizing disorders in girls may reduce referrals. Higher rates of internalizing disorders in girls may mislead us when we're focused on the anxiety and depression that can accompany ADHD in girls. We may forget to look underneath for the ADHD. This delays diagnosis and treatment. Some of the important associated features of ADHD in girls and women include emotional lability and dysregulation. While addictive technology use is common for many people with ADHD, studies find that addictive social media use is more characteristic of girls and women with ADHD than boys and men. Women with ADHD have high rates of risky sexual behavior, compared to their non-ADHD peers, including multiple sexual partners, risky sexual partners, earlier sexual activity, less frequent use of contraception, victimization. Women with ADHD are 6 times more likely to become mothers before age 20 compared to non-ADHD peers. And complicating this pregnancy detail, oral contraceptives are associated with up to 5 times higher rates of depression for women with ADHD compared to women without ADHD. That takes us right into some of the challenges of the menstrual cycle and menopause for women. Even when you look outside of ADHD, some phases of the menstrual cycle are associated with increased activity levels and impulsivity. Imagine that multiplied by pre-existing ADHD. In a survey of 750 women who said they had ADHD, 67% reported they had PMS or postmenstrual dysphoric disorder during their childbearing years. Compare this to about 28% of women in the general population who report those symptoms. Retrospective recall of pregnancy for women with ADHD is mixed. About 20% reported better functioning, including better function, motivation, organization, and sleep. But 36% said their ADHD symptoms got worse with exhaustion, poor memory, emotional dysregulation, and sensitivity. It's probably relevant to mention that 98% of these women said they stopped taking stimulant medication during pregnancy, which means they were not receiving that part of their treatment plan. Let's look at what researchers have found about pregnant women with ADHD. Pregnant women with ADHD are more likely to continue smoking and drinking alcohol than women without ADHD. They experience higher stress levels, less social support, and have increased risk of depression and anxiety, as well as higher incidence of complications during pregnancy and birth. About 61% of women with ADHD report postpartum depression lasting at least a year. There's an emerging body of research about what menopause looks like for women with ADHD. There's some indication that these women may have earlier onset of menopause and more symptoms, more troubling symptoms. Thinking about treatment options, the same treatment options are available for women that are available for men. They seem to work. There are a couple of notes, though. Some researchers have found that hormonal levels can affect the efficacy of stimulant medications, which would be a factor during menstruation as well as around and during menopause. This could also be a consideration for individuals taking hormones for gender affirming care. Many women are anxious about taking stimulant medication during pregnancy and while nursing. But there's also the risk of increased impairment if these women are not taking their medications. One final treatment note for girls and women. When monitoring treatment response, make sure you're choosing symptoms that are specific to that individual. Don't choose a rating scale that does not include that person's level of functioning. Make sure it is normed for girls and women, rather than just assuming it included women and girls in the sample. I'm excited to say that there are a couple of studies looking at ADHD in transgender and gender diverse individuals. This emerging literature suggests that if you look just among these TGD groups, there are higher rates of ADHD than in the general population. If you flip it and look at a clinic sample of children with ADHD, there are higher rates of those children endorsing items about, I wish to be the other gender, and for parents endorsing gender variants of these children. I hope we learn more about this. It's important not to avoid studying something just because it's hard to get a big enough sample. So what happens with gender and when people are first diagnosed with ADHD? Look at these stats that came from a 2023 survey. What do you notice? These are some numbers that jump out to me. It's even more stunning when you start grouping the stats. 61% of women were not diagnosed until adulthood, whereas 60% of men were diagnosed before 18 years old. This has a huge real world impact given the outcomes associated with delays in diagnosis and treatment. So, speaking of outcomes, if you want more information about this, watch last year's webinar on adolescent to adult ADHD. I did a deep dive there. This is a reminder that there are huge impacts of what comorbidity is associated with. The more diagnoses, the worse the outcome in most cases. There are impacts on social, emotional, behavioral, legal, education and employment, medical, dental, and health. Even if you don't care about an individual, looking at the societal level, the economic costs are staggering. Annual excess costs are per year costs spent for someone with ADHD above and beyond the typical cost for someone of that same age group. Every year. Unfortunately, this 2006 headline on a commentary is still true. For adults, ADHD is more likely to be diagnosed if you're a white man. Children are most commonly diagnosed at 6 to 11 years old, but remember that's more for the boys than the girls. Adults, as we just looked at, are more likely to be diagnosed in adulthood than in childhood. And as we just looked at, age and race have significant impacts on age of diagnosis. Unfortunately, this continues to follow the same trajectory that we are doing a better job of referring and diagnosing ADHD in white samples across the lifespan, followed by Black samples. The lowest attention is being given in Asian and Native Hawaiian, other Pacific Islander groups. Poverty is another factor we need to be aware of when we're thinking about context for an ADHD assessment. Let me give you a point of reference. This blue line showing the highest rates is below the 100% threshold for poverty in the US. For 2025, that 100% poverty level for a family of 4 is $32,000. There's a 15% lifetime prevalence of ADHD for children and families living on incomes at that blue line level. Once you go to the higher income levels, which remember, that red line is really just $64,000 a year for a family of 4, that drops to 10% lifetime prevalence. So I can't leave you with all these negative data without saying that there are some encouraging things we can do individually in our own communities. We can help address and reduce these disparities in ADHD by increasing the study of ADHD in all demographic groups. By learning how each person views ADHD, we can provide more appropriate education rather than trying to just give everyone the same packet. It's important to engage people with respect instead of pathologizing or dismissing different opinions and perspectives. Learn where families and individuals turn for help, and then engage those people as community partners. In addition to looking for ways to reduce language barriers, reduce other barriers. Try embedding services in places where children and families and adults are already going. Make services accessible, not just through physical access, but also through logistical access, like providing services after work hours or on the weekends. Pause again. Think about your answers the first time you saw this reflection slide. What more can you add now? Our next category we're going to talk about is DSM-5 diagnostic criteria. Reflect on and actually actively jot down everything you can think of from the DSM-5 and ADHD diagnosis. Make sure that you're including details about age-based diagnosis. Okay, I bet all of you included symptoms. Remember, the symptoms come from criterion A. Some of you may have remembered that there are 9 symptoms for inattention and 9 symptoms for hyperactivity and impulsivity. You probably remember that you need at least 6 symptoms in one or both of in one of those categories, or from both 6 from each. How many of you remember to add this DSM-5 change that if you're 17 or older, you only need 5 symptoms in a category? Okay, bonus points if you remember the rest of criterion A. These really important details are written into the intro above the list of symptoms. The symptoms have to be persistent for at least 6 months. They must interfere with functioning or development, and they must be inconsistent with developmental level. Those are necessary for the symptoms to count as symptoms. Furthermore, they have to impact functioning, negatively and directly impact social, academic, or occupational functioning, and not just due to oppositionality, defiance, hostility, not just due to lack of understanding. If you don't meet the rest of those criteria, the symptoms do not count. Criterion A is more than just a symptom checklist. But wait, there's more. How many of you remember to include B, age of onset? Here's another place the DSM-5 changed the rules. It used to be that you had to have evidence of impairment before 7 years old, and that has shifted doubly. It is now the impairment is not required, just evidence of symptoms, and before 12 years old. Criterion C is pervasiveness, that those symptoms are present in at least 2 settings. Note when you're looking at the DSM, this is not limited to school and home. If it was, we'd never diagnose an adult. The DSM expands what we mean by settings. There are a variety of activities that can help you count for these settings, even if symptoms are not as obvious in school. That's especially important for these girls where we're looking at ADHD. Remember, they may be flying under the radar. Their teacher ratings may look squeaky clean. Criterion D is the impairment. Now, notice we already talked about this up in criterion A. The DSM authors included it twice. That's how important it is that we establish that these symptoms interfere with or reduce the quality of the person's functioning. And then who knows what E is? Yep, the differential diagnosis. This is one I have found over the years most people skim through and skip over. I really view ADHD as an exclusive diagnosis, meaning that you must exclude everything else before you conclude it's ADHD. It's really essential to think about differential diagnosis. Autism is an interesting subject here. It used to be an exclusion that you couldn't have both ADHD and autism. Now they are permitted as comorbid diagnoses. And if you have not yet registered for Sam Goldstein's webinar, it's not too late. Maybe Parul can drop that link in the chat for you. Another sidebar under differential diagnosis is remember that emotional lability in women can be part of ADHD. It is often misdiagnosed as bipolar disorder or borderline personality disorder. The vice versa is also true. So if you run into this dilemma with a woman presenting for an ADHD evaluation or something else, consult with colleagues, check in with someone who has a background in borderline and bipolar, just so you can think through whether the symptoms are more consistent with ADHD or something else. I This is not where the DSM diagnostic criteria end. We've got A through E, which is probably better than if you just had the symptom list from A. But there's also text description that follows those the A through E criteria. And it's really important to read through the text description because you will miss something if you don't. For example, the DSM 5 tells us why age of onset changed from 7 to 12. It also reminds us that symptoms vary by context. The specifiers are another important piece of ADHD diagnosis from the DSM. Presentation, these are the old subtypes. Whether it's in partial remission, this would be a good diagnosis to use. If you think back to those data on children up into early adulthood that went through periods where they had earlier symptoms and diagnosis, but they were not currently showing full symptom presentation. And then finally, the current severity, which is based on number of symptoms, severity of symptoms, and level of impairment. So thinking now, how would you answer this reflection slide on what are the DSM criteria? I bet you have more details to add. And I'm certain that you have more about age-based diagnosis. I have this picture to remind you that ADHD is not a one-size-fits-all. The DSM criteria were developed for hyperactive boys. They're not a great fit for all of the groups where we know ADHD exists. It's important to follow DSM-based diagnostic guidelines, but to have an enriched understanding of how the symptoms appear in different groups. Let's think about ADHD presentation at different life stages. Pull out your paper and pencil, jot down some reflections. What do we mean when we say ADHD over the lifespan? What ages does that include? What part of the lifespan are you most familiar with? Does ADHD even change with age? I start lifespan and ADHD with preschool. Now, it's really hard to detect ADHD in preschoolers because it's developmentally normal to have a short attention span, high activity level, and limited impulse control. This is where it's really helpful to have norm referenced parent and teacher ratings like you can get with the CAARS Early Childhood. Looking at a community sample that was collected in Illinois, they looked at 4 years old and 6 years old. About 48% of 4-year-olds who were diagnosed with ADHD still met criteria at 6 years old. But that means 52% of those 4-year-olds no longer met diagnostic criteria. And vice versa. 52% of the 6-year-olds who met criteria for ADHD had not met criteria at 4 years old. Overall, 93% of the sample did not meet criteria at either checkpoint. I think these statistics just remind us that it's probably a smart idea to take some response to intervention approaches when we're looking at preschoolers. In the most extreme cases, you may want to proceed with referral for medication, but the American Academy of Pediatrics recommends starting with behavioral approaches at this age. Some exciting news is there's an early ADHD consortium that has been formed by some international collaborators. They're going to prospectively study early signs of ADHD, much like we did with autism a couple decades ago. So stay tuned for more data about how we can recognize ADHD earlier. School-age children, this is the age group probably most of us have been trained on and have practiced in thinking about ADHD. I got to say again, girls in this group are often missed. Common age of first diagnosis in childhood is 6 to 11 years old. That motoric hyperactivity as you approach adolescence is going to start shifting into internal restlessness. In school-age children, as they get older, we have some emerging comorbidity. Remember those slides we looked at earlier showing increasing rates of anxiety and depression, especially in girls. The treatment team is really important to include parents and school providers. Um, be mindful that parent-child conflict that happens over this age span is exacerbated when one of the parents has ADHD as well. Parent training can help mitigate that dynamic. Adolescents, we continue the shift in symptom presentation, the comorbidity shift as we looked at. A survey of 750 women with self-reported ADHD recalled their adolescence as being characterized by prominent feelings of sadness or depression, rejection-sensitive dysphoria, and greater worry or anxiety. There's some key associated features to watch out for in this age group. Suicidality. 18.4% of youth with ADHD made at least one suicide attempt before age 18. This is compared to only 5.7% of comparison youth. Self-injury can increase in this age group, like cutting, sleep disruption. Adolescents with ADHD tend to have fewer plans for their future than their peers, especially girls with ADHD. This is a time span when we are decreasing supports and increasing demands. That's a bad equation for someone with ADHD. This shows up academically, where compensatory strategies may no longer be sufficient. It can show up as underachievement, anxiety and depression, symptoms of perfectionism. Social interactions become more complex, and we provide less adult scaffolding, supervision, and support. Teens with ADHD often have difficulty with maintaining friendships, resolving interpersonal conflict. We see social isolation and rejection sensitivity, and a risk of turning to a non-desirable peer group like the burnouts, sexual dependence, and gangs. Consequences become more severe, especially as teens experiment with adult behaviors like sex and substance use. We also see an increase in substance seeking for enhanced focus or financial gain. In terms of diagnosis and assessment, I'm going to say it again, we still miss girls at this age. I really want you looking out for the girls. Rapport building is essential when you're working with an adolescent for any evaluation, including ADHD. Include in your conversation why you're doing the assessment and what are their observations, what's important to them. It's essential to get self-reported data given the many internalized aspects of ADHD that are not visible. Thinking about treatment, it's really scary. A 2022 survey found that 30% of youth with ADHD were receiving no treatment at all. That's an increase from 2016 when 23% of youth with ADHD were not receiving treatment. Reasons for not receiving treatment in this age group include non-English speaking households, just being an adolescent, low levels of adolescent desire, less parent monitoring, forgetfulness, and then the adolescent belief that no change is needed. So what can we do to improve outcomes for these teens with ADHD? It's important to educate teens so they understand and are invested in their treatments rather than being forced. A study of primarily Latinx and Black adolescents with ADHD found increased engagement in treatment when treatments were tailored to match goals provided by the adolescents, and they were given options rather than being told this was the only choice. Within individual therapy, there is support for cognitive behavioral therapy, some emerging support for modified dialectical behavioral therapy or DBT, especially when it's modified for teens with ADHD. It's important to consider self-concept and self-image, especially thinking about girls who have those sexual risks, help them build strong sexual concepts. Parent education can be powerful. educating parents about increased risk for teens so they can engage resources earlier in the process, and building protective factors so we can reduce the presence and severity of later negative outcomes. Don't wait until high school graduation to introduce real world survival skills like meal planning, scheduling, and communication. Go ahead and introduce these skills early so that your teen has lots of practice before they hit the adult world. Just a quick reminder that for older adolescents and adults, the DSM-5 criteria shift. And as we move into emerging adulthood, remember that the brain is still developing, especially those white matter tracts that connect everything. The brain's not fully wired yet, and we're being encountered with new challenges like identity development, individuation, exploration of roles, and attempting independent living. We have greater risks when we make mistakes at this age. Social risks like impulsive proposals or unplanned pregnancies, emotional blowups that lead to injury or legal issues instead of going to the principal's office. Behaviorally, car crashes are very different when you're driving a full-size vehicle instead of a matchbox car. And cognitively, things like skipping work can lead to unemployment instead of just losing 10 points on your final grade. Financially, impulsive spending doesn't just mean you're out of allowance, it means you have a bad credit rating and debt. We have fewer protective factors as we move into this age group. Parents are less in the picture, and that 504 team that wrapped their arms around this teen are no longer holding their hand. Diagnostically, we have some challenges that enter the picture. It's harder to find reliable observers when these young adults are no longer living at home. Their professors may not know them as a person. This is the age when a lot of psychiatric disorders began emerging, including first psychotic episodes. And again, we're just not as good at catching ADHD in young women. But we're getting closer. 25 to 44 is when most women are likely to receive their first diagnosis of ADHD. Within that emerging adulthood group, I want to take a minute to think about college students. There was this huge study of almost 16,000 first-year college students. This was just a survey. It was not diagnostic, but 16,000 people in the study, and 16% of them had a high ADHD score. 58% of these students scored high in other categories too. So this is not a diagnosis, but I think it is important to recognize that this large percent of our college students were describing symptoms of ADHD and severe impairment. I personally would love to know more about how ADHD shows up for college students. Over the years, Keith Connors, Drew Earhart, and I have brainstormed sets of items for a college-specific ADHD rating scale, but it has not been developed for distribution yet. If any of you think this is an important project to pursue, I'd love to know that. That could help motivate our team to move forward with it. Please scan this QR code or use the link that Parul is dropping in the chat to answer a one-question poll. Thank you. So adulthood is a huge group, but unfortunately, most studies do not divide it into smaller subsets. In general, most experts report that symptom presentation often becomes more subtle in adulthood, but I'll tell you that is not always the case. I have absolutely seen some adults who you have no difficulty seeing the ADHD. There is no subtlety at all. Research tells us that in terms of the inattentive features, inattention tends to be more prominent than hyperactivity and impulsivity in adults. It can be hidden behind compensation that takes extra time and energy, like working extra hours and exhaustion. It can lead to burnout in relationships when others have to cover for forgotten, late, and incomplete tasks. People with inattentive features in adulthood struggle when a topic is not personally interesting in comparison with having sustained attention to interesting tasks. Attention can really be affected by environmental factors. Many adults with ADHD describe this inner feeling of chaos, plus just disorganized lives, feeling unsettled, turbulent schedules, disorganized physical environments, and irregular sleep eat cycles, a real need for external structure. This is even more exacerbated for adults who have children or who are managing households, especially when their partner or children have a diagnosis of ADHD. Hyperactivity in adults often shifts into that restlessness, that internal sense, and effortful control of physical movement during time limited events, difficulty relaxing, preferring jobs and settings that allow physical movement, and some say excessive talking could be seen as hyperactivity. Impulsivity tends to be more social, things like being intrusive, oversharing, blurting things out. Emotional dysregulation goes here for me. Quick anger, low frustration tolerance, being overreactive. And then those risky behaviors often persist, especially things like reckless driving, unprotected sex, extreme sports, impulsivity around substance use, even for someone who didn't mean to use, and impulsive spending. Outside of those diagnostic characteristics, other features of ADHD in adulthood include low self esteem, feeling different and misunderstood, hiding ADHD and trying to fit in, difficulty building and maintaining relationships, underachievement and underemployment, and self medication, which unfortunately, the side effects are often worse for ADHD. Awareness of symptoms and their impact on others, awareness of emotions and self and others, those tend to be skewed for adults with ADHD. There are some strategies that help, things like organization, routines, use of reminder apps, having the option to adjust your own environment, taking time for physical activity, learning self talk that helps reduce self blame, medication consultation, especially with someone who listens to the specific concerns rather than just treating. Discussing side effects is an important part of that too. Accommodations, not just at school, but also at work, individual therapy and support groups, and a strong predictor of the strategy that works is having a supportive partner, friend, or family member. Childhood ADHD is associated with lots of adult patterns, but most striking, the symptoms persist. Even if someone technically did not meet full DSM criteria, there are still impairing symptoms that affect a number of domains. There's some nice studies that describe the lived experiences of adults with ADHD. A survey of 4,000 women with ADHD said that 70% said ADHD had a life altering impact during their 40s and 50s, including procrastination and time management, working memory problems, feeling overwhelmed and disorganized. Most adults have an initial reaction to diagnosis that they are relieved, but that's followed by doubt and existential questions about identity and regret that they were not diagnosed earlier. Most adults who get an adult diagnosis of ADHD say it helps explain why they have always felt different. It reduced their self blame and it helped them understand what was previously inexplicable. So, how often are we missing ADHD? A study of US adults with ADHD found about half of them had received some kind of mental health treatment in the previous year, but only 13% were treated for ADHD. That means 87% were missed. Another study found that 56% of adults with ADHD had complained about symptoms in the past, but not diagnosed before. So, what should we look for so that we don't continue missing ADHD? It's a little overwhelming, these stats that I'm about to read to you. Several studies have found any mental health diagnosis is associated with higher risk of ADHD, even one mental health diagnosis, especially if it's anxiety or depression. You increase the probability of ADHD if someone has been treated for anxiety and depression and did not respond as expected. Um, Adults who have higher healthcare resource utilization are more likely to have a diagnosis of ADHD. And if there's a first degree relative, that's another sign that ADHD may be in the picture for this adult. Moving into late adulthood and elderhood, the prevalence numbers look lower here, but remember the impact of methodology. There are some other factors in why we have lower rates of diagnosed ADHD in this age group. Part of it is the historic context. The DSM criteria did not explicitly include adult-based examples until 1994. And adults born before World War II tend to have lower help-seeking behaviors. It's unlikely that this is a true difference in actual occurrence of ADHD. It's more likely that this is just a bias in who we're capturing. The core symptoms are the same as seen in earlier adulthood, although sometimes older adults report their symptoms as less severe. This could be related to coping strategies, acceptance, reduced demands, or lower awareness. Some of the ADHD-related deficits lead older adults to present for dementia evaluations, and they are so relieved to learn that they have ADHD, which is not progressive like dementia. Some older adults with ADHD are thrilled to have high energy and ability to stay busy compared to their same age peers who do not have ADHD. ADHD with older adults need to consider both dementia and ADHD as possible competing or coexisting diagnoses. There are some shared medical risks that are associated with both conditions, including obesity, smoking, hypertension, head injuries, and psychiatric comorbidities. It's important that we look at ADHD when we see older adults instead of assuming that it would have already been caught earlier. There's evidence that older adults with ADHD have these same comorbidities, but at higher rates. We continue seeing the fallout from ADHD. The new differential diagnostic considerations that come in for us at this part of the lifespan beyond dementia include that we've increased the probability of other factors, medical factors. It can be harder to find good informants, especially information about onset of symptoms. That family history of ADHD can be a good thing to turn to. And then remember medication interactions and side effects as factors when you're doing an ADHD diagnosis in an older adult. David Goodman says that gaining insight into ADHD in older adults is crucial, as the population of individuals aged over 65 will nearly double from 2012 to 2050 in the United States. Pause and reflect on how you answered these questions a few minutes ago. What would you add or change now? As we head into discussing assessment techniques, remember the DSM diagnostic grid we created. We're going to revisit this from the perspective of how each assessment modality can help capture relevant diagnostic data. Go ahead and jot down all the ways you can gather data in an ADHD evaluation. Think about how those might change for different age groups. Make sure you're covering all of the DSM criteria. And think about what else do you need to get from an assessment beyond diagnosis. All right. Here's some of the modalities we're going to cover. Thinking about record review, where are you getting records? Why are you reviewing them? And what changes across the lifespan? So, one of the things that I notice changes is availability. So, young children have fewer records, but it's pretty easy to get them through the schools. As you enter young adulthood, you start to lose access to records, partially because high schools purge their files after graduation, and young adults rarely have their own records. Ideally, the young adult will either give you a signed release to get records from their parents if their parents saved them, or they will talk with their parents and families about what they looked like in childhood. Uh, Independent living adults sometimes have a box of records, and you might need to motivate them that yes, it is worth digging it out of the attic. I will tell you, I have some cases where people have brought me two huge duffel bags of records, and it has been worth it to go through them. So keep that in mind. You may choose to get releases and request records directly if you're working with an adult who has ADHD and it's hard for them to follow through on, yeah, I did get diagnosed 10 years ago and I don't have a copy. The school records are not as detailed as they used to be. I think there's more fear of lawsuit and bigger class size. So there's just less information. When you can get school records, it can help balance out recall errors because they're snapshots of this person at different ages. They can help you document evidence of symptoms before 12 years old. They can suggest differential diagnosis considerations like language disorder or dyslexia. They may include progress monitoring or end of grade testing or even AIG testing, academically, intellectually gifted. So you may have some IQ scores or academic achievement results that will help you with ruling out other considerations. Remember, you may need to apply a filter. The same child might be described as high spirited by one teacher and willfully disobedient by another. Mental health records, when you can get them, can help you know about symptoms, onset, impairment, persistence, pervasiveness, and impairment distress. They can help with the differential diagnosis piece. But remember, that is one snapshot, one point in time. Clinical presentation may become more clear down the road. It may be more obvious to see symptoms of ADHD as demands increase and supports decrease. Remember that presence of psychiatric medications does not necessarily mean that someone has a diagnosis. Medical records can help you as you're thinking about ADHD, especially for things like comorbid or competing diagnoses. Were the symptoms present before this person had their head injury, stroke, or heart attack? Or did they start after that event? Medical records can also help you identify that pattern of things associated with ADHD, like injuries associated with physical impulsivity. In my private practice setting, I rarely review legal records, but I always ask about these topics. Forensic psychologists and providers working within incarceration settings are more likely to have these records that can provide information about symptoms, especially impulsivity and attention to detail, and associated features like emotional flare ups. Sometimes legal records can provide information about onset, a setting where symptoms are present, impairment, and severity. Similarly, I rarely review actual employment records in my setting, but some of you may be working in HR or employee assistance setting and have access to those records. I always ask about these topics. I wonder about things like timeliness, consistency and variable performance, time management, prioritization and follow through, response to communications. Employment information can give us a valuable source of information about symptoms, settings, impairment, and severity. What about interview? Who are you interviewing? How are you interviewing? Why are you interviewing, and what changes across the lifespan? For children, my initial diagnostic interview is usually with parents and guardians who give me that historic context to establish onset, pervasiveness, persistence, and impairment. I always complete a separate interview with the children instead of relying entirely on the parent interview. Even during a parent interview, I'm starting my observation process given the high rates of heritability of ADHD. For adolescents, I still start with a parent or guardian interview, and I add a full length interview with the adolescent. For adult evaluations, I typically begin with the client, and I always use the margin to note my real time behavior observations. It can be hard to get the childhood history from adults. Plus, insight and awareness can be impacted by ADHD. So, whenever possible, I try to get a secondary informant for a separate interview. With young adults, after you get that release, ask if you can interview parents or guardians, perhaps by phone or video if they're not local. It's best when they can come in. It's important with these young adults and also with the teens to check in on the boundaries of what you're asking about and what you share. You may need to compromise on certain topics. You may need to tell the adolescent or young adult, I ask this question in every interview, and I'm glad to clarify for your parents that it is a standard question, not specific to you. That may be necessary for you to get to the real data. Remember that for these young adults, parents may have limited information about their current functioning. Parents may be a better source of historic data rather than current. Consider, and this is a squirrely age, and I don't have a one size fits all recommendation here. In some cases, I will ask about roommates, friends, coworkers, family members. Honestly, I more often say, how would your friends describe you? Or what do you hear from your professors and your coworkers? In terms of how I do this, I have gotten more comfortable with virtual meetings for people I already know, but I refuse to do it for a first interview. I lose too much data. I have to go ahead and meet in person for that initial contact during the interview so that I can observe eye contact, body movement, fidgeting, get that physical sense of impatience and restlessness, pick up on the pace of conversation. When you meet by video, you also lose all the information about how a client enters the space, what they leave behind in the waiting room or your office, how they respond to environmental cues. So, for those reasons, my initial interview is always in person. If you are new to ADHD evaluations in an age group, or if you don't do them very often, I strongly encourage you to look at structured and semi-structured interviews. Those of you involved in research almost always use these so that you have a more consistent data set. When I was at Duke with Keith and Drew, we developed a semi-structured interview for ADHD. It was later published, but that is no longer in print. The things that I see that are out there that are available include the Diva 5 for adults. There's a Young Diva 5 for parents and children who are 5 to 17. They even have a version for use in adults with intellectual disabilities. The SKID 5 comes in several lengths and formats and has an ADHD module. It was developed for use with adults, but it says you can modify the wording to use with adolescents. I don't use a semi-structured or structured interview at this point, but I do still pull out the DSM-5 every single time. I always begin with an open-ended question like, have you ever wondered about a diagnosis of ADHD? Or what do you know about ADHD in children or in adults? or what makes you think you might have ADHD. I then listen for data to support each part of the DSM criteria. If the person is tangential or wandering, I make a behavior observation note before I begin introducing more structure. I keep track of which criteria have been spontaneously mentioned and then follow up on the ones that have not. Remember, you want information about presence, absence, frequency, and intensity about each of the 18 symptomatic criteria. You need that for the severity specifier as well as for diagnosis. Before we leave this interview slide, remember that a good clinical interview will cast a broad net. If you over-focus on ADHD, you will miss other relevant information about competing or comorbid diagnoses. You're more likely to misdiagnose if you only focus on ADHD. Other things that are essential to accomplish during your interview include identify key treatment targets. What is this individual motivated to change? What about their family? Sometimes people use questionnaires to streamline interviews, but I would never substitute a questionnaire in place of an interview. Behavior observation is the next modality. What are you observing and how? Where and why? And what changes across the lifespan? So here I'm talking about my direct clinical observations. When you start gathering observations from the client, that's part of the interview. And rating scales is another way we gather observation data from people beyond you. Here I'm talking about our clinical observations. If you're not using a structured clinical observations system, think about what is your personal experience with this person. How do they engage before the first appointment? I began observing when I received the referral. I pay attention to how organized the person is. Do they give me context when they leave me voicemails and phone calls? I pay attention to how many reminders someone needs to complete their registration materials and what kind of errors there are in their paperwork and payment. I'm not overly focused on the presence or absence of ADHD. I'm just looking for flags for those among other things that could be part of the clinical picture. How does this person enter your clinic, your waiting room, your office? Do you hear them coming? Are they juggling multiple things? Are they on time? Do they look frazzled? Are there multiple trips in and out because they forgot something in the car or the waiting room or your office? Do they miss your cues like you're using a quiet voice? During your conversation and interview, do you find you're needing to organize and structure and rein them in? Are you exhausted by trying to keep up? Are you confused with where they went from your question? Is it hard for this person to work quietly during testing or filling out paperwork? Do they need you to repeat questions? What happens with structured versus open-ended questions? Are they leaving enough space for you to join the conversation, or is it just a constant flow? Do they talk over you or ask questions before you finish? Look at what parts of their body are moving. If you're sitting at a desk, scoot back so you can see their feet and legs. Sometimes I put a footstool under the desk just to see if someone fidgets with their feet. That way I can hear it. Notice if they're picking at their nails, their cuticles, bumps, skin. What happens with jewelry, hair, and clothing? If you leave a pencil or paperclip on the desk, does it become a fidget? Does the person seem distracted by environmental cues like a bird outside the window or someone entering the waiting room? Are they distracting to you or other people because they're humming, drumming, rattling their ice, talking too much, or moving too much? How do these behaviors interfere with your interaction and communication? Do they make it harder for you to accomplish tasks? All of these are valuable elements of diagnosis, assessment, and treatment. How do you do this? There's structured observation systems that often have a mix of different time periods, different times of day, time sampling, specific behaviors. There's some commercially available observation systems like the BOSS, the classic classroom observation code. The Achenbach system has a direct observation form, and Ken Gadow and Associates have their ADHD school observation code. A lot of those are focused on children in school settings, and they're helpful, especially for research or when you're trying to develop a sense of what and how to observe. Some clinicians are in school settings and you can easily get school-based observations. If so, I encourage you to look at structured and unstructured settings. It's rare for those of us in private practice or academic settings to be able to go to home, college, office, or community settings. There are unique opportunities for those of you who are in residential settings like boarding schools, rehab centers, detention facilities, and retirement communities. Leverage those opportunities that you have. It's really important to make these behavior observations so that you can think about intentional or unintentional bias and how clients and their families present symptoms. It's important to add our professional trained observer data to the equation. Our direct observations require less guesswork, and they may identify key targets for intervention. So, what changes by age for behavior observations? Remember that for many adults, that blatant hyperactivity and impulsivity may become more internalized. Even if someone looks like they're sitting still, don't assume that it's easy. Ask about how much effort it takes for the person to sit still and what is the person going to do with their energy once they leave your office. Pay attention to the chattiness and missing social cues, as those are also signs of hyperactivity and impulsivity in adults. Let's look at rating scales. How do you select your rating scales? Who does them and why are you getting them? What's going to change across the lifespan? This may seem obvious, but when you're selecting a rating scale, make sure it has developmental comparisons that match the age group you're looking at. And if you're looking at a girl or a woman, make sure the normative sample includes girls and women. Again, that seems obvious, but you should not assume it. I can say with certainty that the CAARS rating scales have demographically representative samples, but check. There are others that do as well. In addition to looking at ADHD specific rating scales, you may also want to include impairment rating scales, like Goldstein and Naglieri's rating scale of impairment for 5 to 18-year-olds, and the Weiss functional impairment rating scale, which is for adolescents and adults, plus there's a parent form for children. You want to think about what is the content. Is this a broadband rating scale or is it a focused one that has more in depth? Is it DSM-based and does it reference the DSM-5 or a previous version? As boring as these details are to me, I know some of you love them, all of us need to look at development details when we're selecting a rating scale. We need to look at the normative sample. Is there a clinical comparison? Are the scales valid and reliable? How are they with sensitivity and specificity? How do they do at detecting bias? What is the reading level? How is it completed? Is it paper, pencil? Is there an online option? Does it have the ability to get self-report as well as observer report? And what types of observers are included in their norms? I'm going to focus in briefly on 2 rating scales that I know a lot about. I was involved in the development of the CAARS 4, but I don't receive any royalties for its use. I chose it because I know that the research and development process at MHS is exceptionally thorough. You can see a large normative sample. The content includes ADHD plus common co-occurring issues. It is DSM-5 based, It has strong psychometrics, including being gender inclusive and meeting fairness standards. The reading level is very accessible, third grade for self-report. It has a couple of different administration options and a parent, teacher, and self-report forms. If I choose to use a measure that was normed on a group of 100 faculty children, I want to know that those norms may not be relevant for a child I'm seeing in a public school setting being raised by a community member who only has a GED. Other commonly considered rating scales for children and adolescents include the Vanderbilt, which is popular because it's free, the CAARS Comprehensive or CBRS, which is like the CAARS 4, but in a broader context, the Brown, EF, and attention scales, Achenbach's Child Behavior Checklist, which includes an attention problem scale, and then, of course, the BASC that includes executive functioning and attention problems. Thinking about adults, focus on the CAARS 2, which we are so excited to have out there in general use. I'm not saying you have to buy the CAARS 2. I do get a small amount of royalties if you do, but I'm using it as an example of what you should look at when you're reviewing manuals for other adult rating scales. It's a nice feature that we have these integrated lifespan assessment options in that the CAARS 4 and CAARS 2 have parallel structures. We developed them around the same time, so we shared ideas with each other to improve both of them. That makes it easier for clinicians who are trying to integrate data from earlier as child and adolescent assessments with current adult scores. Other commonly considered rating scales for ADHD in adults include the ASRS-5 by Adler and colleagues. It's just 6 questions and it's available online. Barkley's BARS-4, which is aligned with the DSM-4, and then the Winder Utah rating scale, which is retrospective report of childhood symptoms. Turning to testing, this is a very controversial subject. Remember the bias. I am a neuropsychologist. It's second nature for me to consider standardized tests and an evaluation, but they're not technically necessary for an ADHD assessment. It's always important to ask yourself, why are you giving this test? How will this process or these results benefit your client? If you can't justify it, don't do it. So, if a psychiatrist refers someone to me to ask, is a medication trial appropriate for this adult who has finished their education? I'm probably not going to need as much documentation. I'm probably not going to need testing. But if I'm seeing someone who's still in school or looking at going to school, I probably will need standardized testing for documentation purposes so that they can get the necessary accommodations and data-driven strategies. I find standardized testing gives me valuable behavior observations. I'm used to what this subtest looks like for most people this age, and it's noticeable to me when someone does it differently. Test results can be important to include for that differential diagnosis. For example, if attention problems only appear in the context of reading, I want to know if this person has dyslexia in addition to or instead of ADHD. Test results can guide treatment planning, especially adaptive functioning testing or executive deficit testing. Test data can help make recommendations about individual strengths, which can inform what accommodations and treatment strategies are relevant. So which tests do I use? Well, I mean, it really depends on what I'm testing for and why. So IQ testing, I find, is a really reliable way to gather a variety of observations in a short amount of time, and it's essential if intellectual disability is part of the determination. Academic achievement testing, if there's a specific disorder, specific learning disorder. It could be that someone with ADHD looks bad on academic testing because of the attentional factors. But remember, the very nature of a structured testing environment may make them look better. That same thing is a bugaboo with attention testing. I often give a Connors CPT if I'm doing standardized testing, um, but it only tells me about someone's performance in those conditions. Someone may truly have ADHD and look fine on the CPT because they can keep it together for under 15 minutes. When someone gets a low score or elevated scores on some parts of the CPT, that really goes a long way for establishing impairment and severity. Keep in mind that tests of attention can also be impacted by reasons other than ADHD, such as brain fog of menopause, long COVID, stroke, concussion, grief, trauma, dementia. It's important to interpret our test results in context so that we can understand whether these are pervasive, persistent deficits or things that developed later in life or are only obvious in certain contexts. Executive dysfunction often accompanies ADHD, so it can be helpful to evaluate to better describe ADHD-related impairment. Hopefully you caught Jack Naglieri's webinar on executive functioning earlier this month. Uh, Sometimes test of visual attention, no, visual processing or language can give you an opportunity to look at organizational deficits as well as ruling out other issues. Memory and learning are important to test, especially if you're working with a student or seeing someone for a possible dementia evaluation. People with ADHD can have low or inconsistent scores on cognitive speed tests. Pay attention to how they got those. It may be that it's not just their brain speed, it's that they were off task or distracted internally. You got to understand why they got those scores. And then many people with ADHD have fine motor deficits. So fine motor skills can be helpful for establishing accommodation needs and interventions. What has changed in your answers now that we've talked about these different assessment modalities? Okay, as we move from assessment modalities into application of knowledge, go ahead and pull out your DSM-5 grid again. We're going to add some more notes to it now. Also, jot down your thoughts about how we can use all of these assessment modalities to inform DSM-5 diagnosis and whether we care about more than diagnosis when we're doing an ADHD assessment. So here's the grid that you already have. We're going to add these columns to it. You have a printable version of this grid in your handout file, and I'll ask Parul to drop a link in the chat as well. So, what assessment modalities help us gather information about criterion A symptoms? Some people start and end with rating scales. Now, absolutely, well-normed, psychometrically sound rating scales are an important part of ADHD assessment, but that's not the only part of this criterion. Do most rating scales establish persistence for at least 6 months, interference with functioning or development, inconsistency with developmental level, negative impact, level of understanding and behavioral factors? Some behavior rating scales, like the Connors 4 and CAARS 2, include aspects of interference, negative impact, and behavioral factors, but most do not. The strong normative samples on rating scales can help establish whether symptoms are inconsistent with expectations for age. But remember, in the case of IDD, you also need cognitive testing to determine whether symptoms are inconsistent with developmental level. Impairment rating scales can help with examining interference and negative impact. Record review and interview are absolutely necessary to determine persistence, interference, and impact on functioning. And your observations are necessary for considering possible bias from other reporters. With children, adolescents, and adults in school settings, Standardized testing can help document the need for accommodations, but I don't always complete standardized testing with adults who are no longer in school. What about onset? Which assessment categories can help us establish the evidence of symptoms prior to 12 years old? I think record review and interview are the most commonly used to document age of onset for adolescents and adults. When you're assessing children, parent and teacher rating scales plus your observations can establish presence of symptoms prior to the 12-year-old cutoff. What about pervasiveness? Presence in at least two settings like home, school, work, relationships, other activities. Rating scales, that's one of my number one go-tos for pervasiveness, including teacher ratings for preschool children, adolescents, and observer ratings from someone familiar with the adult, which can provide information about functioning at home. We also need our parent rating scales for those preschoolers, children, and adolescents. Your behavior observations can provide data about presentation across settings. You might be able to observe in the parking lot, the busy waiting room, structured testing, casual conversation. Just remember that some people with ADHD can look pretty good for a brief, structured office interaction, even though they struggle with daily life. Record review can give you information about pervasiveness, especially if you have access to teacher information. A well-phrased interview is also meaningful. In addition to listening for those spontaneous examples of where ADHD shows up across settings, ask guiding questions like, what are your favorite things about your job? And what are the hardest things about your job? While standardized testing is not necessary to establish pervasiveness, the presence of symptoms, even in a structured, reduced distraction one-on-one setting, can provide evidence of one setting. What about impairment? Where do we obtain clear evidence that these symptoms of ADHD interfere with or reduce the quality of social, academic, or occupational functioning? Once again, record review and interview are essential. Remember to look for a pattern of impairment, not just isolated examples. Your behavior observations can be relevant, but there's a caveat that absence of symptoms in the clinic setting does not mean total absence of symptoms. For some people, it takes longer sessions or multiple sessions for symptoms to be observable. It's unusual for me to specify severe if I see nothing in the clinic setting, but I might use the specifier of mild if I don't see it, but others do. When someone describes high impairment, but I'm not seeing it in the clinic, I often ask what they feel like after meetings and appointments. If so, I ask why and what happens when they leave. I ask if they have strategies they use to mask or manage symptoms of ADHD, and what is the cost of those strategies. Looking at rating scales, some behavior rating scales, like the CAARS 4 and the CAARS 2, include functional impairment items. There's also the option to add impairment rating scales like the RSI or WIFRs that I mentioned earlier. Testing can help establish impairment, such as when a student is bright but loses points on timed tests due to losing focus or correcting impulsive and intentional errors. I wouldn't test just for that purpose, but if I'm already giving standardized measures like to rule out dyslexia, I absolutely include those data in my ADHD decision grid. Where do we get information about criterion E, differential diagnosis? We want to know if symptoms occur exclusively during the course of schizophrenia or other psychotic disorders, and whether they're better explained by another mental disorder like mood, anxiety, dissociative, personality disorders, intoxication, or withdrawal. This DSM-5 criterion is another reminder that we need to always cast a wide net instead of only looking for ADHD. Remember that many of these conditions affect attention and impulse control. It's our shared responsibility to consider alternate explanations to be sure ADHD is the best one before we assign a diagnosis. I often picture a funnel when I start an assessment. I begin at the wide end and work my way down to the narrow tip. Record review and interview are necessary to examine onset and course, which can help with part of the differential diagnosis process. Looking for information about emotions is relevant to ADHD as well as to possible competing or coexisting disorders like depression and anxiety. Finding out when and where symptoms happen is necessary too. Be intentional when you think about behavior observations. Do not use this as code for mind reading or gut feeling. Make sure this category is truly observable features. You may have developed strong clinical intuitions, but use these as a motivation to look for observable evidence. Saying someone feels like a borderline is not sufficient. What are the observable patterns that support a diagnosis of borderline personality disorder versus ADHD? If you're not sure, seek additional information and possibly a professional consultation or second opinion. In terms of rating scales, you can include rating scales that flag other areas. The screener items on the CAARS measures are a beginning. You can add content-specific scales like the Children's Depression Inventory, the Multidimensional Anxiety Scale for Children, or the Autism Spectrum Rating Scales. In some cases, standardized testing is necessary to rule in or rule out other diagnoses, especially learning disorders, language disorders, autism spectrum disorder. We talked about IQ testing if you're considering possible intellectual developmental disorder. That also helps us establish developmental expectations so we can determine if ADHD is comorbid versus the symptoms are consistent with their developmental level, and therefore no ADHD diagnosis is needed. Before we leave this grid, let's add one more line. Treatment planning and monitoring. How do these assessment modalities help you fill out this line? Can they help you identify key targets as you plan and monitor treatment? I find valuable information from all these modalities when I think about treatment. If something is expressed in report card comments, it's a potential treatment target. If parents and spouses describe something as the most frustrating thing, or they say, if I could just figure out how to change this one thing, that's going to be a treatment target. When you observe something that interferes in your communication, your interaction socially, or task completion, that could be a target. And then rating scale results can help you identify possible targets. Maybe you pick the highest score or the highest scored items within an elevated scale. So what would you change in your answers to this slide now? I hope your answer to the second question is no. Diagnosis alone is not sufficient. Most people don't come for an assessment just because they want a diagnosis. They come because something's making life hard and they want it to get better. One last piece. Let's go back to that case study. You remember this referral? Think about what contextual information do you already have and what else do you need to know? What assessment methods are you going to choose to guide this question? I'm going to give you some additional information from record review and interview. This 25-year-old woman uses the pronouns she, her. She qualified for a gifted program due to high IQ and academic achievement testing scores when she was young. She described that her AB transcript does not show that she had many late and missing assignments, but she aced tests due to strong memorization skills. She attempted a traditional 4-year college, but was put on academic probation in her first year due to class absences from oversleeping. Her professors did not accept late papers, and she was missing knowledge because she often ran out of time or forgot to complete assigned reading. She had to withdraw. She's currently living with her parents, working part time, and taking 2 community college classes. What else do you need to know? If you said you want to get a rating scale, I'd agree. I'd give her the CAARS 2 to get self reported data. And since she's living at home, I'd ask for a release and get her parents to complete observer ratings. Results from the CAARS 2 are going to help us get information about DSM criterion A. Interview questions that would be important to include are: what made college different from high school? I have some guesses, but I want to gather data rather than assuming. Like, how much did her parents and tutors support her in high school? Was there a lenient policy about replacing late and missing grades? Were tests based on regurgitation of knowledge, and now she needs to integrate, infer, and apply? Did anything change with her self care between high school and college, like sleep and nutrition? I'd want to know about onset. Were the difficulties present in some form before 12 years old? Persistence. Have these symptoms been persistent over time? Remember, different levels of demands and supports may mask her symptoms of ADHD, but she should have some evidence of symptoms for this to be truly ADHD. And what about pervasiveness and level of impairment? Where do symptoms interfere with her life? Not just at school, but also in the community, work, family, and friends. I'm curious, where is she working? It tells me something different if this bright, knowledgeable person is getting minimum wage for making pizzas. There's a lot to consider for the differential diagnosis. I want to know what's going on emotionally. Does she have any past or current symptoms of anxiety or depression? A depressive episode could present this presentation. A flare-up of anxiety could also look like this. Where is she with substance experimentation and use? Does she have any head injuries in her history? Are there other areas of concern like social interaction difficulties with you, with teachers, with same age peers? In my mind, I'm wondering, do I need to rule out high functioning autism? Maybe she needed the support and structure of daily high school classes and living at home. Maybe she has autism with comorbid ADHD. Another angle on social functioning is lack of social supports or an exclusive dating relationship that isolated her from friends before a devastating breakup. Don't forget your clinical observations. What's your experience with her? Do you need to increase structure to keep her on track in the interview? Does she need frequent reminders of her appointments? What's her affect look like? Let's take the same referral, but I'm going to change some details. This 25-year-old woman has the pronouns they, them. We have no previous testing or diagnoses. They worked in high school to help with household expenses and to save for college. They live with a single mother who is unemployed and receives Social Security disability payments for a medical condition. They continued living at home and working while taking community college classes and completed their associate's degree in 4 years. They transferred to the state university as a junior and are continuing to live at home and work part-time while earning a bachelor's degree. So what's different now? This started with the same referral. What has context changed for you? And your assessment? We know there's an increased risk of missing ADHD given this individual's context, non-binary, lower income level. We for sure want to ask about social supports and mental health. Research studies find there are elevated rates of anxiety, depression, and substance use for LGBTQIA plus individuals, plus increased risk for PTSD and suicidality. Regardless of diagnosis, I want to know, are there protective factors that I can strengthen, like connection with community or support group? What is their relationship like with their family? Are they able to be open about identity and struggles at home? Are there any past chronic or current traumas, including bullying, discrimination, or abuse? Are they in a supportive relationship? Are there any past or current thoughts that they'd be better off dead, or past history of self-injury? Are there financial stressors for this individual that could be reduced by getting them connected with university and community resources, resources for them, for their mother, for their siblings? Are they overwhelmed because of ADHD? Or do they just have an overwhelming life? Are there additional details that are relevant, like transporting younger siblings to and from school, doing grocery shopping and cooking, picking up mom's prescriptions? Where did their A's and B's come from? Were there flags for ADHD, or are they consistent and steady with getting everything done? Are there symptoms of ADHD in other parts of their life? What do the rating scales show? I ask you to continue working through the DSM and assessment grid. Make sure you're covering the bases. There are infinite ways we could adjust the case study, and we're out of time to discuss them in this webinar. Perhaps you and your colleagues can continue the conversation. Choose different scenarios by changing age, gender, race and ethnicity, income, cognitive abilities, level of family support, availability of records and informants, comorbid and conflicting conditions, and so on. No matter which combination you consider, our integrated approach to an ADHD assessment is going to remain the same across the lifespan. We're going to consider contextual factors, review all aspects of the DSM-5 criteria for ADHD. Each component is essential. Reflect on the individual's age and life stage, including what we know about presentation and assessment as they shift. Be intentional about a multimodal assessment, combining techniques and tools to give you a full picture of where this individual matches an ADHD diagnosis and where they do not. And remember why we do what we do. The ultimate goal is not to label, but to connect this person with services, supports, and strategies. Thank you so much for your interest and your time today. I hope the information you got from this webinar will be helpful in your future ADHD assessments. Due to technology and other logistics, I can't be with you for live questions today, but I leave you in the capable hands of our MHS team. Thank you.
Let's move on to the Q&A. We are pleased to have Joanna Solomon, our Manager of Psychometrics, here to address questions related to today's topic. Welcome, Joanna.
Pearl, thank you.
We have a couple of questions. So the first question we have is to know your thoughts on late onset ADHD. This is happening a lot during midlife for women, and there is a concern of premenopause is being misdiagnosed as ADHD.
That's a really interesting question, and this was actually of particular interest when Elizabeth, Dr. Sparrow, and I were developing the CAARS with the rest of the team. And it's one of the main reasons we ensured that the normative sample includes a very wide age range, extending up, I believe, into the 70s and 80s. I mean, we really tried to make it as broad as we could for adults. And we checked to make sure that the structure of ADHD doesn't vary across age. Like, it's still the same symptoms, still measuring in the same way across the whole lifespan. Thinking about midlife is a super interesting contextual factor that's important to consider when evaluating, especially women going through menopause or other things that might explain the presence of some of these symptoms and might actually look like ADHD. And it's one of the reasons Dr. Sparrow encourages such a comprehensive evaluation process to gather a huge amount of information so that you can do that differential diagnosis with as much ammo as possible, really.
Thank you. The next question we have is, what are some screenings that do include research on girls?
Ooh, Dr. Sparrow mentioned this, that the CAARS 4 and the CAARS 2 were actually designed very thoughtfully to include research about the presentation of ADHD symptoms in girls and in women specifically. So for example, the CAARS 3, the previous iteration, had a scale about anger, and that was actually revised in the newest version, the CAARS 4, to be more about emotional dysregulation broadly, to better capture that wide range of presentations you get across different gender groups.
The next question we have is about diagnosing ADHD when there is an established history of challenges in report cards throughout elementary school. Teachers and the child client report notable challenges, but parents deny any significant issues at home. So what do you think about this one, Joanna?
That's a very challenging situation. And I think this is one of the reasons Elizabeth, in her talk here, mentions all the importance of such a wide variety of information to make a diagnosis. You really need that multiple perspectives. You need the input from the parent, from the teacher, from the student themselves, from the records, from the observations, from the interviews. It's entirely likely that a parent might have a motivation not to be entirely honest, or they might be fearful of what a diagnosis might mean, that it has some stigma attached, or there's other concerns. That might be unintentionally not disclosing information because they truly don't have that kind of insight. Maybe the child doesn't behave that way at home and it isn't a problem, it doesn't create any impairment. So it's really interesting to get multiple perspectives and put all the pieces of the puzzle together as part of a comprehensive evaluation.
Yeah, that's a great solution. The next question we have is, when assessing for potential ADHD in adults specifically, what performance-based cognitive measures are considered most sensitive to ADHD and useful in differential diagnosis? And how do you integrate those with self-report measures like those discussed here?
That's a really important question because, as Dr. Sparrow mentioned, it's not just about rating scales. It's not just about one measure or one indicator, that it is really valuable to get information from a variety of different things. Any kind of standardized test can really, really help, especially performance-based ones. In particular, I'm thinking of something like a continuous performance task, like the CAARS CPT test suite, where you actually have stimuli on screen that really captures omissions or commissions and reaction time, and you can get a very objective measure of somebody's actual performance, not just the behavior and symptoms as described by themselves or their raters. And there's a lot of research that shows that it adds incremental validity. So putting that together with a self-report or a parent-filled rating form really does increase confidence in a diagnosis. You can see consistent patterns often. It strengthens the decision-making power and guides interpretation. Often it guides treatment and intervention planning as well.
Yeah, thank you for explaining that, Joanna. And the last question we have is, how does the partial remission piece work for diagnosis since ADHD is lifelong?
A very good question. Dr. Sparrow mentioned that the absence of symptoms in a clinical setting doesn't always mean the total absence of symptoms. And I think what she may have meant by that is that it is difficult to observe and it does fluctuate over time, which might be a challenging part of the diagnosis process. There's a lot of factors that go into this. So there's a combination of environmental factors. For example, somebody who is 18 and just starting university for the first time and dealing with, a million new responsibilities and accountabilities and perhaps has less control over a lot of their symptoms, as opposed to somebody in a very rigid workplace where a lot of the challenges they might otherwise face are actually held in check. There's developmental challenges to consider, motivational challenges. I think some of what you might observe is developing coping strategies or tools and systems to mask or work through and deal with these kind of challenges that are presented. I think partial remission can happen, but the symptoms will fluctuate over time or just appear to be masked given a different context and a different scenario. And that is a really important thing to consider in the context of an evaluation. That is not just one point in time, that a lot of these symptoms actually do need to be present for an extended period or have that childhood onset or have some kind of persistent presence in somebody's life.
Thank you so much, Joanna, for your support and for answering all the questions. We have more questions, but we could not include all because of the time limitations. Once again, we extend our heartfelt thanks to Dr. Sparrow for such an informative presentation. And thank you to all our attendees for joining us today. If we did not get to your questions during the webinar, please email us at marketing@mhs.com and we will forward it to Dr. Sparrow. With that, we have reached the end of the session today, and we wish you a wonderful rest of your day. Thank you.